Hi everyone, here I come up with another video section. In this section I teach about cardiovascular system diagnostic measures, which includes what are the various diagnostic tests performed to rule out the cardiac diseases. We start from laboratory examinations to the radiological examinations. Here see what are the assessment parameters. First one is cardiac output. Cardiac output in the sense it measures the effectiveness of the heart's pumping ability. Then cardiac output is defined as the amount of blood that leaves the heart in 1 minute. So to calculate the cardiac output, we use the formula that is stroke volume into heart rate. Normal cardiac output is approximately 4 to 8 liters per minute. And cardiac index in the sense cardiac output per square meter of body surface area. That is calculated by cardiac output divided by body surface area. As seen earlier, cardiac output in the sense stroke volume multiplied with the heart rate. So first of all, we see what is stroke volume. Stroke volume is the amount of blood that leaves the heart with each beat or ventricular contraction. As you know, especially the stroke volume, that is during each heartbeat, the amount of blood that leaves from the left ventricle, that is noted as the stroke volume. So the thing you're supposed to understand is the whatever the quantity of blood or the amount of blood which is collected in the ventricles will not there is no 100% of blood is ejected. Okay, the norm in a normal adults there is a 70 ml per beat. There is a almost we say 70 ml of blood will eject, otherwise it will be pumped out of the ventricles during each heartbeat. Then ejection fraction. Most often you may have seen in your echocardiogram reports, there is a term is ejection fraction that is usually presented in a percentage. So what is ejection fraction? Ejection fraction, the percentage of N diastole blood actually ejected with each beat or ventricular contraction. During the ventricular depolarization or ventricular contraction, what is the percentage of blood is pumped out? The normal range is 50 to 70%. That is, if the person has a healthy heart, then the 55 to 70% of blood will be ejected in each beat. Then stroke volume. In the stroke volume, there are three factors which regulate the stroke volume. First one is preload. Preload in the sense the degree of stretch of ventricles at the end of diastole. As you know, during the diastole or the end of diastole, the blood will be collected over there. So during that stage, the degree of stretch of the ventricles is termed as preload. Second aspect is contractility. Contractility in the sense force of ventricular contraction. Otherwise we say systole or we say depolarization. That is using the inotropic period. That is what we say contractility. Then third factor which regulates stroke volume is afterload. Afterload in the sense the amount of resistance the ventricular wall must overcome to eject blood during systole. Otherwise we used to say afterload in the sense the amount of pressure exerted by the ventricle wall to eject the or to pump out the blood during ventricular systole. So further I discuss about this in the continue with the stroke volume. When discuss about preload in the sense already said it is. Then here the degree of ventricular stretch, that is what the degree of ventricular stretch at end diastole. According to the Frank-Starling law of heart, increase preload, it will increase the contractility to a point. Then, which are the factors it may affect the preload? Certain factors it affect preload like circulating volume. Circulating volume in the sense, what is a blood volume? Otherwise, intravascular volume. Based on the quantity of volume, it will affect the preload. For example, it may affect it during hypovolemia or hypervolemia. That's the difference. During hypovolemia, the amount of preload also decreases. During hypervolemia, amount of preload, otherwise the quantity of blood collected is the increases. Then body position, according to the which position we are lying and all, it will also affect the preload. Then atrial systole or atrial kick. Then medications, certain medicines that affect are diuretics, AC inhibitors and IV fluids. Diuretics, as you know, the drug of choice, furosemide or Lasix we say. So it will excrete more volume of blood pumped out of the body. So diuretics affect the preloads. Similarly, AC inhibitors, angiotensin converting enzyme inhibitors. So what AC inhibitors does? It will prevent the conversion of angiotensin 2 to angiotensin 2. Thereby, it will reduce the uh, blood pressure level in the vascular status. So that stage also that will affect the preload. Similarly, IV fluids, according to the level or quantity of fluids we administer, that will uh, simultaneously affect the preload of the heart. Then second aspect we said is the contractility. Contractility, it is a positive inotropic agent. When there is a positive inotropic agent means it will increase the force of contraction. Then if you are administering the negative inotropic agents, then decreases the force of contraction. Already said contractility means amount of effort that is the ventricle wall happens during the systole. So it most often happen with the automaticity or during this electrical activity. So when there is inotropic agent that will directly affect the contractility power of the ventricle walls. So when there is a positive inotropic agent, it will increase the force of contraction. When there is a negative inotropic agent, it will decrease the force of contraction. Then what are the factors that affect contractility? First of all, autonomic nervous system. Then medications like digoxin, beta adrenergic blockers and calcium channel blockers. So these drugs, beta blockers and calcium channel blockers especially, they are the antihypertensive category. It will reduce the contractility of the ventricles. Third aspect is afterload. Afterload, there is a resistance to ventricular ejection during systole. So what are the factors that affect afterload are? First one, outflow impedance, that is left side in the sense high systemic blood pressure or uh, systemic vascular resistance or aortic valve stenosis. In this situation, there is a left side, there is a affect the afterload. Then if you see the right side of the heart, because of high pulmonary blood pressure, that is pulmonary vascular resistance and pulmonary valve stenosis. Similarly, other factors that affect the afterload include diameter of arterial vessels, then blood characteristics and certain medications, especially angiotensin converting enzyme inhibitor. So next we see what is heart rate. Till now we have seen about the stroke volume. What is stroke volume? What are the three factors that regulate the stroke volume? That is preload, contractility and afterload. Now what is heart rate? As everyone knows, heart rate in the sense the beats per minute or how many the number of times heart beats in a minute, that is what we count as the heart rate. So to understand, increasing heart rate means it will increase the cardiac output to a point. Especially why it says means during arrhythmia also heart rate increases. So there is a thing we supposed to know. If the heart rate increases more than 160 beats per minute, then it decreases the heart rate, cardiac output. How it decreases cardiac output? Because it leads inadequate diastolic filling time. So when there is a inadequate diastolic filling time, there is a ventricular filling, decreases the ventricular filling. So what happens? Decreased time for coronary artery filling and an increased workload of the heart. So ultimately there is a decreases the cardiac output. Then factors which affect heart rate are certain medications, especially atropine sulfate, digoxin, beta blockers and calcium channel blockers. Atropine sulfate, it will increase the heart rate, whereas the digoxin, beta blockers and calcium channel blockers, that decreases the heart rate and thereby it decreases the workload of the heart. Then assessment considerations. So while doing cardiac assessment or cardiac examinations, we are supposed to consider the general cardiac symptoms. What are the major symptoms presented by the patient? Based on that, we prefer the assessment. Then, for example, the symptoms include fatigue, chest pain or discomfort, palpitations, shortness of breath, edema, weight gain, dizziness, syncope and loss of consciousness. So first of all, in the assessment, we should collect the what are the chief complaints or the presenting symptoms of the patient. Then special population. What kind of population or who all we supposed to consider while performing any kind of diagnostic test? First of all, the gerontology consideration. That is, when considering the elderly, what we supposed to know. So when considering elderly, the heart function is adequate at rest, limited ability to respond to stress and takes longer to return to baseline. Usually their heart will be weak and as well as it take time for the normal stage. Then decreased sensation of chest pain tend to be under quantified or even absent. Then general consideration about women. Smaller heart and coronary arteries tend to present with atypical symptoms of coronary artery disease. Then other consideration like diabetes mellitus and cardiovascular disease. So increased threat and decreased symptoms. In the sense, patients with the diabetes, if they develop the cardiac disease, most often they will be seems asymptomatic because they have the diabetic neuropathy. So that they don't sense the chest pain. So threat of life is more among the patient with the diabetes. Then what are the laboratory tests we perform to rule out the cardiac disease? First one was serum enzymes, otherwise we used to say cardiac markers. Then on blood test, we study about lipid studies, that is lipid profile, electrolytes, renal function studies. Then coagulation studies and hematological studies. First, see about cardiac enzymes or serum enzymes, or we say cardiac biomarkers. The first and foremost biomarker, that is creatine phosphokinase, or in short term we used to write CK or CPK, that is creatine phosphokinase. So when consider about the creatine phosphokinase, it is a non-specific cardiac enzyme. Why means this creatine phosphokinase elevated with damage to heart or any skeletal muscles and brain tissues. So thus it is said as it is a non-specific cardiac marker. Okay, not only with the cardiac or myocardial damage, it also secreted with the injury to the skeletal muscles, also injury to the brain tissues also. Patients, what is that? The blood presence with the creatine phosphokinase. So it elevates in 4 to 8 hours after injury and it peaks at 15 to 24 hours and returns to normal in 3 to 4 days. There is a time period of when it start to secrete or when it start to release to the blood or when it reach the peak level and when it is returned to the normal. Then second one is a creatine phosphokinase isoenzyme. In short, we write CPK-MB. So this is what the specific cardiac biomarker. Okay, why it is specific? Because isoenzyme of CPK elevated with the cardiac muscle damage. So CPK-MB, otherwise we say isoenzyme of CPK, which elevates only because of cardiac muscle injury. So it is a specific cardiac biomarker. So it is usually elevate in 4 to 8 hours and reach the peak level at 15 to 24 hours and returns to normal in 3 to 4 days. It is the same. Next cardiac enzyme is a myoglobin. Myoglobin is also a non-specific cardiac marker because a heme protein found in muscle tissue elevated with the damage to skeletal or cardiac muscles. Either even it used to elevate due to cardiac muscle damage as well as it increases due to skeletal muscle damage. So when see the time duration, it elevates in 2 to 3 hours and it peaks at 6 to 9 hours and returns normal in 12 hours. Next one is the LDH, that is lactic acid dehydrogenase. So this is also a non-specific cardiac marker. This enzyme elevated with the damage to many body tissues. Examples: heart, liver, skeletal muscle, brain and RBCs. And not frequently used today because it is not a genuine or not a reliable marker to rule out the cardiac disease. So, regarding the time period, it elevates in 1 to 3 days, it peaks in 2 to 5 days and returns to normal in 10 to 14 days. Next one is the troponin I or troponin T. This is the most reliable one. Similarly, it is a specific cardiac marker. So, a contractile protein released with the cardiac muscle damage not normally present in serum. So, how it is? The time duration is it elevates in 4 to 6 hours and it reaches the peak level in 10 to 24 hours and returns to normal in 10 to 15 days. So, thus it is says it is the most reliable one because within 4 to 6 hours it start to release as well as it reached the peak at 10 to 24 hours and it will exist in blood till 10 to 15 days. So the thing is the sensitivity superior to CKMB within the first 6 hours of event. So has replaced LDH for clients who delay seeking treatment. Next one is the other serum enzymes. First one is C-reactive protein. C-reactive protein, that is a protein marker of acute inflammatory reaction. So increased serum levels associated with increased risk of acute cardiovascular events. Next is the homocysteine. So this is the amino acid presence in serum suggests increased risk of cardiovascular event. Then natriuretic peptide. So hormones like substance released into bloodstream with the cardiac chamber distension. So atrial natriuretic peptide or brain or B-type natriuretic peptide, that is what the usually diagnostic test. Then other thing is lipoprotein or lipid profile. As you know, the lipid studies or cholesterol analysis that is used to differentiate or diagnose whether the patient have the risk for any cardiac disease. So total cholesterol level supposed to be less than 200, that is what the normal range. And triglyceride, that is normal is less than 150 milligram per deciliter for an adult. And low density lipoprotein, otherwise LDL, is supposed to be less than 130 milligram per deciliter. So optimal in the sense the good factor is it's supposed to be less than 100 milligram per deciliter. And high density lipoprotein, that is a good protein, that is a HDL. The normal range is it is more than 40 milligram per deciliter. So more than 60 milligram per deciliter means it's a cardiac protective factor. Then serum electrolytes. Usually the patients susceptible for cardiac disorders, we usually analyze the serum electrolytes sodium, potassium, calcium and magnesium. In my previous video already discussed about imbalances in the electrolytes. So sodium normal supposed to be between 135 to 145 milliequivalent per liter. Potassium level is 3.5 to 5.5 milliequivalent per liter. And similarly calcium and magnesium levels also described over there. Then glucose hemoglobin, that is HbA1c, glycosylated hemoglobin level. Then coagulation studies to rule out the blood coagulability. So that is analyzed by partial thromboplastin time, activated partial thromboplastin time, then prothrombin time and international normalization ratio. These are the studies used to rule out the coagulation. Then hematologic study, that is complete blood count. It starts from hemoglobin, then differential count, platelet count, similarly ESR. All these studies are relevant to rule out the cardiac diseases. Then renal function test. In renal function test, we analyze blood urea nitrogen and serum creatinine level. Then next we move on the what are the diagnostic tests. First of all, electrocardiography. The electrocardiography, that is a graphical presentation of the electrical activity of heart. This electrocardiography usually we analyze by taking the 12 lead ECG. So it continues bedside monitoring also we can say, as well as ambulatory monitoring. So this is what the link you can follow or you can watch in this link regarding more detail about ECG. What is ECG? What is ECG paper? How to calculate heart rate from ECG, as well as what are the parameters regarding to electrocardiograph. Next one is a stress test. That is in detail we see that stress test for the thallium scan and echocardiogram and cardiac catheterization. These are the further, other than the laboratory or the chemical studies, these are the other diagnostic tests which are performed to analyze the cardiac condition. First of all, cardiac stress test. Already I said ECG is discussed in another video that you can watch and learn. Then stress test, that is in the sense stressing the heart to monitor the performance. So what is stress test? Otherwise it is usually called treadmill test. Okay, treadmill test. The patient or the person is supposed to allow to walk on a treadmill, and the electrodes, cardiac electrodes or the chest leads as well as the limb leads will be connected, and that leads are connected to a monitor. So these electrophysiological parameters or the electrical impulses captured, and it will be transferred and displayed on a physiological parameters in the monitor. So the duration will be for 12 to 15 minutes of time. Every 3 minutes, the speed as well as the height of the treadmill is the modified. So we generate the stressing the heart, then look after how the heart can cope up with the more powerful or more stressful situations. That is what the stress test. So in this test, it assists in determining the coronary artery disease, causes of chest pain, functional capacity of heart, identify dysarrhythmia, effectiveness of medications, and establish certain goals for a physical fitness routine. Then we see what are the different types of stress test. So exercise test, that is we use the treadmill, that is what the most common type, and bike test and arm crank. Then pharmacological means vasodilating agents to mimic the effect of exercise like persantin and adenosine. Then mental or emotional, that is under investigation only, that is simulated public speaking as well as mental arithmetic test. Next is the thallium scan. Thallium scan, in the sense it is often combined with the stress test, is a radiological exam to assess how well the coronary arteries perfuse the myocardium. The images are taken 1 to 2 minutes prior to end of stress test and again 3 hours later. The nursing consideration is we are supposed to explain the patient to be nil per oral and should generate a intravenous success. This is what the nursing consideration while performing the thallium scan. Other nursing considerations like explain the procedure to the patient, maintain nil per oral, that is for 4 hours before test, and instruct client to avoid stimulants like chocolate, caffeine and cigarettes, and hold certain medications before testing. That is when we are performing the exercise stress test, we are supposed to withhold the beta adrenergic blockers, that is antihypertensive, and when we are performing the pharmacological test means we just withhold theophylline, that is a bronchodilator, that is especially 24 to 48 hours prior, and IV access must be obtained. because any kind of emergency we can expect. So immediate treatment, to activate the immediate treatment, the patient supposed to be with the IV access. Next is the echocardiogram. As you all know, echocardiogram, there is an ultrasound procedure of heart combined with an electrocardiogram. It assesses cardiac geometry, that is size and shape, and motion of structure, that is in the sense chamber walls and valves. That is, it is a non-invasive procedure, so we can visualize the flow of blood, kinetic activity of the heart valve, as well as the walls of the ventricles. Then simultaneous ECG assistant interpretation. So it can be done in conjunction with the stress testing, referred to as a stress echocardiography or exercise echocardiography. Then what are the types of echocardiograms? Mainly two types are there. Transcutaneous echocardiogram, that is what the non-invasive painless one. Next to the transesophageal echocardiogram, that is an invasive or clearer images it develops. Transesophageal in the sense as it is performed like an endoscopy. A fiber optic tube is inserted through orally and visualize the cardiac function. That is what transesophageal echocardiography. The nursing consideration like explain the procedure and advise the patient to maintain nil per oral 6 hours prior to the procedure. Then IV access should be maintained and NBO 4 hours post procedure, because especially during transesophageal echocardiography, we suppress the gag reflex and all. So we supposed to wait for the return of gag reflex. That is why NBO for 4 hours post procedure time. Then monitor for complications. Then cardiac catheterization. When say about the cardiac catheterization, it is a gold standard of cardiac diagnosis, because that is the most reliable one. It is an invasive procedure and we get all kind of information through the cardiac catheterization. Regarding cardiac catheterization, it is an invasive procedure to assess cardiac chamber pressure. That is, as you know, the cardiac chambers like right and left atrium and right and left ventricles. Each of the chamber has varying levels of pressure, that is systolic pressure, diastolic pressure and main pressure. Then as well as we can analyze the oxygen saturation. Then detect congenital or acute any structural deficits. Congenital anomalies like atrial septal defect, ventricular septal defect, any tetralogy of Fallot, many kinds of congenital anomalies are there. As well as any kind of structural defect also we can identify in the catheterization. Then we can analyze the ejection fraction. Ejection fraction already said, it is the percentage of blood ejected in each beat. Then also often includes coronary angiograph. That is coronary angiography to assess the coronary artery patency. That is already there is a angiography in the sense the invasive procedure to check the patency of arteries. So coronary angiography is to check that is an invasive procedure to check the patency of coronary artery. The coronary arteries are the arteries which supply blood to the myocardium. Then using X-ray technique called fluoroscopy, it required the use of IV contrast or IV dye we inject to analyze the heart. Here see, continue with the cardiac catheterization. Here see about the nursing care. So first of all, the nursing care, that is a pre-procedure care. As a nurse, we are supposed to explain the procedure to the patient as well as the patient bystanders and make them understand what are the risks are there, what is the benefit of doing the procedure and all. Then maintain the patient nil per oral for 8 to 12 hours prior to the procedure. Then check for allergies as we are using dye and all. Explain the patient regarding what is the procedure as well as assess whether the patient have any allergies to dye, shellfish or any kind of iodine, and laboratory tests like all kind of blood values supposed to be collected in advance. Next, during procedure, what we supposed to do? During procedure, the IV access supposed to be patent, because in between the procedure, we can predict for any kind of complications or adverse effects. So we need to administer medications, or we need to give any therapeutic interventions. So there's have should have a IV lines that is supposed to be patent. Then hemodynamic monitoring, all kind of hemodynamic monitoring. There is a parameters, blood pressure, heart rate, and a cardiac activity and all should be monitored in between the procedure. Then arterial and venous access, that is via catheter. Catheter in the sheath. To perform the cardiac catheterization, we need to insert a cardiac catheter. There is a long tube. That tube is inserted through the sheath. That is placed in the femoral artery or femoral veins, or any venous access like radial this one arterial access like radial artery and femoral artery, or venous access like femoral veins and also subclavian veins. So in any area, this they place the sheath. So we supposed to be special care to that sheath, because there is a risk of bleeding is there. Also there is a chances of forming hematoma. Also there is a chances of damage to the arteries. So periodically we supposed to monitor that sheath. Next, nursing care after procedure. After the procedure, maintain the client in the sense we supposed to say patient. Okay, after procedure, maintain patient bed rest for 6 to 8 hours. Especially the extremity should kept straight, and the head of the bed should be less than or equal to 30 degrees. So the extremity in the sense the which extremity we use to puncture the access, that extremity should be straight. Otherwise, there is a risk of hematoma formation as well as bleeding. Then maintain adequate hydration, administer IV fluids, and encourage for fluid intake, because already said there is a we inject the dye and all. So to wash out, otherwise to excrete it properly, the patient should be given adequate fluids if indicated. Then frequent monitoring for complications. So monitor vital signs, that is blood pressure, heart rate, then ECG, that is cardiac monitoring, and everything supposed to be done. Then puncture size to be monitored for bleeding, hematoma. Then similarly distal pulse, that is which area is they inserted the sheath or the catheter. Peripheral to that is a distal area pulse supposed to be monitored periodically, because any risk of damage the arteries are there. Then laboratory result, that like renal function test. After the procedure, as they injected dye and all, we supposed to perform renal function tests, especially urea and creatinine level. Then other blood values and coagulation values supposed to be monitored. Okay, in this section I have reviewed regarding the diagnostic tests which we perform to rule out cardiac disorders or the condition of cardiac system. So that is especially laboratory tests like cardiac enzymes, then other laboratory examinations like blood studies, renal function tests, lipid profile, all these things, including other diagnostic tests like electrocardiogram, treadmill test, otherwise it is a stress test, then echocardiography, then cardiac catheterization. All these sites is a overall review of the diagnostic test, otherwise diagnostic measures which we use to perform in the cardiac assessment. I hope you understand about the video, and subscribe this channel for further theoretical informations. Thank you.